Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, our guests. Now we will start our last session of our conference, starting with Dr. Sami Al-Malki, his speech about the roles and mechanism of stem cell in wound healing. تفضل دكتور سامي.
هذا البوينتر ولا هذا؟ كول. نبدأ ولا ننتظر شوي دكتور؟ نبدأ؟ اوكي. طيب. Assalamu alaikum wa rahmatullah. So my talk today is roles and mechanisms of stem cells, more specifically mesenchymal stem cells in wound healing. So as a start, when we have an injury, wound, the wound healing process would start, which consists of three phases or three stages. So the first stage is inflammation. So during this phase, blood clotting cascades will start to stop the blood loss at the wound site, and the injured tissues and damaged cells at the wound site will release some chemokines and cytokines to recruit or attract cells like monocytes and neutrophils to the site of injury. The macrophages will also start phagocytosis for some pathogens at the site of injury, and will also secrete some cytokines and growth factors that will participate and initiate the second phase of wound healing process, which is the proliferative phase. So what happens during the proliferative phase? In response to some triggers from macrophages and growth factors, cytokines, in the first phase, fibroblasts and epithelial cells will start to migrate and proliferate at the wound site, and will also some fibroblasts will differentiate into myofibroblast. So myofibroblast during this phase will participate in wound closure by contracting at the site of injury and try to close the gap at the wound site. So we will also see some growth factors released from macrophages, like vascular endothelial growth factors, which is well known for its role in the angiogenesis. So angiogenesis will start to take place in the second phase, and we will see formation of new blood capillaries to supply the wound site with nutrients and oxygen and other requirements that are needed to facilitate the process at the end. And in the third phase, maturation, so we will start in this phase. This phase basically is to make sure that the remodeling and the collagen deposition, the extracellular matrix on the microenvironment at this site, especially in the dermis layer, are going in the right way, and there are many molecules, including some enzymes like matrix metalloproteinases, that will participate in this phase, and will make sure that the extracellular matrix and the microenvironments at the site of injury are going in the right way. So what are the factors that affect or influence the wound healing process? There are some local and systemic factors. Local factors include ischemic tissues, contaminations, infections, especially bacterial infections, and tissue pressure. And systemic factors include age, diabetic patients, diabetes, stress, obesity, smoking, and nutrition diets also may affect that. So traditional treatments are going on till these days, are including addressing systemic factors, especially for diabetic patients, to correct the blood sugar, local wound care by dressing changes, and the administration of antibiotics, especially if there is bacterial infections, and as a last choice, tissue grafts. And the problems with tissue grafting is we have limitations with angiogenesis. So the formation of new blood capillaries, when we have tissue graft, especially allografts, the angiogenesis process won't go in the right way. Also, we have limitations with graft rejections. And for these reasons, scientists, physicians start to look for new ways to solve these problems or to treat chronic wounds. So this study, in the last 2 decades, we have seen some new clinical trials that focus on new ways of treatments for especially chronic wounds. So this study was published in 2016, which compared the treatment of chronic diabetic foot ulcers with amniotic membrane and versus the standard care, the standard wound care. So what they found in this study was involved 100 patients were involved in this study, and they found that the wound complete closure within 3 months or 12 weeks was in 97% of patients who were treated with amniotic membrane allograft, and 51% only of the patients who were treated with the standard care were achieving the complete closure after 3 months. Also, they found that the cost of treatment with amniotic membrane was 4 times lower than the standard care treatment. Another study also studied the effect of amniotic membrane allografts versus multi-layer compression, which consider also as a standard wound care. 84 patients were involved in this study, and they found that a proportion wound achieving 40% within 1 month, where 62% for allograft group and 31% was for the standard care or control group. After 1 month, the size of wound reduced to 48% with the patients in group of allograft, and only 19% in the control group. Well, this explains a lot. So, although we don't have stem cells in the amniotic membrane, but we have some cells that express some growth factors and cytokines, and that facilitate the process of wound healing. And that opened the door for other scientists to think in a broad way and start thinking about using mesenchymal stem cells for the treatment of wound healing, since those cells can express growth factors, cytokines, and facilitate the process of wound healing. So we can use mesenchymal stem cells. From our background, we know mesenchymal stem cells can express some growth factors, can secrete some cytokines and chemokines, and has immunomodulatory roles in different diseases. So, talking about stem cells and mesenchymal stem cells specifically, so mesenchymal stem cells, are also known as adult stem cells, have the ability to differentiate or are capable of differentiating into different types of cells, and they also known for their self-renewal, and proliferative activities. So MSCs can be isolated, or mesenchymal stem cells can be isolated from different sources, including muscle, placenta, umbilical cord, bone marrow, and adipose tissue. And here we will focus on adipose tissue for some reasons. So adipose tissue have the same characteristics of other stem cells, and mesenchymal stem cells specifically. So they can adhere to black adhesion, so we can isolate those cells, culture them, and in normal plastic flasks. They also have self-renewal capabilities, and they can differentiate to different type of cells. The one specific features about adipose tissue as a source for mesenchymal stem cells is the abundancy of mesenchymal stem cells and abundance of the source itself in patients. So when we have a patient, we want to do in future, inshallah, want to do treatment for this patient, we can get a portion of fat tissue from abdominal fat or any parts of the body, and we extract mesenchymal stem cells from those from the fat, culture them and use them for treatment based on type of disease. So this is a paper was published last year. So here we were trying to summarize the most recent findings that stem cells were involved during the treatment or clinical trials to treat wound healing. So many studies have shown that mesenchymal cells have the ability to secrete different growth factors, for example, vascular endothelial growth factor, fibroblast growth factors, and HGF. And those growth factors can participate in the angiogenesis and cell proliferations. And as we know, this angiogenesis and cell proliferations are very important processes in the wound healing process overall. Also, mesenchymal stem cells can express or can secrete other growth factors like prostaglandins 2 and transforming growth factors beta and other growth factors that can facilitate the proliferations of fibroblasts, reepithelializations, and collagen depositions by fibroblasts. Also, it was found that mesenchymal stem cells, especially adipose-derived mesenchymal stem cells, can secrete tissue inhibitor matrix metalloproteinases. And this is one of the enzymes that inhibit matrix metalloproteinases enzymes that main function is to degrade the extracellular matrix and allow the migration of other cells, also to do the remodeling process during the wound healing process. So TIMs, or tissue inhibitor matrix metalloproteinases, are very important during this process, during the wound healing process, since they participate to inhibit the matrix metalloproteinases and control the whole process not to go into chronic wound at the end. Other factors, other cytokines have very important roles during the process of wound healing. And these are the major cytokines, major interleukins, and other growth factors that participate in the whole process of wound healing. And from here we can notice that this type of cells can be used in wound healing as they secrete and express the major factors that help the wound healing process during the three phases. So also different studies have found that mesenchymal stem cells, especially adipose-derived mesenchymal stem cells. So mesenchymal stem cells isolated from adipose tissue can also secrete different cytokines that can participate or work as immunomodulatory effects by MSCs. So we need immunomodulations by MSCs at the site of injury, so we can control the inflammations, the first phase of the wounds process, and also the inflammatory phase, proliferative phase, and so on. So also different studies in the last few years have reported that mesenchymal stem cells have some secretomes, or also called exosomes, and those exosomes carry different stimulators and different regulators that can participate, for example, in stimulation, statutory act, and ERK pathways, signaling pathways to induce the angiogenesis process. Also, these exosomes or secretomes can stimulate T regulatory cells and macrophage M2 or M2 macrophages, and that has immunosuppressive and anti-inflammatory effects at the wound site. Also, the exosome created from mesenchymal stem cells can stimulate fibroblast keratinocytes, as we said, and stimulate the migration, proliferation, re-epithelialization process at the end. Also, these exosomes have some other molecules like small non-coding RNAs and other type of RNAs that can inhibit some signaling pathways and macrophage 1, and that participate in the anti-inflammatory effect at the end of this process. So are we here yet? I think no. I think we're still far away, but hopefully in future we'll be there. So for this reason, and based on the findings, so we designed our experiment based on that. And the big question was, does hypoxia affect the secretion of mesenchymal stem cells, growth factors, cytokines, and all the secretions that participate in wound healing process? So that was the big question. So to achieve that, the experiments was designed so we will isolate mesenchymal stem cells, especially from adipose tissue. We will culture them in DM till passage 3, and then we will do the characterization. So characterization is just to make sure we have pure mesenchymal stem cells, the stem cells that have the ability to express stem cell markers, and they have the ability to differentiate into multi-lineages. So we will examine the adipogenic differentiation, osteogenic differentiation, and chondrogenic differentiation. So when we are done with the characterizations, then it's time to go to the next step, which will culture the cells. We divide the cells into two different groups. The first groups will be normal hypoxic conditions, and the second group will be in 1% oxygen, which is hypoxic conditions for the cells. So after that, the condition media, when it's incubated in these different two conditions, condition media will be collected after 24 hours, and evaluation of the expression of some very important growth factors and cytokines that has key roles in the wound healing process will be evaluated and tested. So I will try to go fast in this, so I don't know if somebody is interested in how to isolate mesenchymal stem cells from mice, but I will try to do this very fast. So in the isolation process, we get the fat from the mice or from mouse, and the fat will be diced using scissor into small pieces. Then we will use, after washing, of course, then we will use collagenase type 1 to dice the fat tissue into small pieces. This process will take about 2 hours, and during these 2 hours we will shake the every 15 minutes or so. So the next step, we will stop the collagenase after 2 hours. We will stop the collagenase activity by adding serum or serum-containing media, and then we will centrifuge the resulted diced tissue, or we'll centrifuge it at 400 ground for 10 minutes, resuspend pellet and serum-free media, and then we will filter it through 100 micrometer cell strainer. So after this process, we will go into the density gradient separation. And what is that exactly? We will use back for the density gradient centrifugations, and we will add whatever we have from the previous step and centrifuge it at 400 ground for 30 minutes. The results, we will have the histoback and the big layer here, the media, and there is small layer. So the diagram here doesn't really reflect the actual size of the buffy coat, but the buffy coat is a very small layer between the histoback and the media. We will collect the buffy coat and put it in serum-free media. We will wash it twice or thrice, and then we will culture our cells in DMEM. After 24 hours, we will change the media just to make sure that we don't have contamination with other type of cells. So now we have the cells. These are the cells after 24 hours of culturing, primary culture, and these after 27 hours, after 3 days of culturing. So we usually get, in comparison to other mesenchymal stem cells, bone marrow and other sources, we get high proliferative rate compared to those types or sources. So part of characterizations, we did immunophenotyping for stem cell markers, CD44 and CD90. Our culture showed a positive immunophenotyping for these two markers, for stem cell markers. And we also examined the expression of different markers like macrophage markers and hematopoietic stem cell markers, just to make sure that we don't have contamination of other cells in our culture. Immunostaining also as an extra step for confirmation that we have stem cell marker expressed in these cells, and we have pure mesenchymal stem cells in our culture. So CD44, CD73, CD90, all are stem cell markers were positive in our culture, or in our mesenchymal stem cells, isolated cells, and they were negative for the macrophage markers and hematopoietic stem cell markers. So after that, we went to examine the ability of the isolated cells to differentiate into different lineages. So we differentiated into osteocytes, chondrocytes, and adipocytes. And to evaluate that, we use allelozarine red staining, which detect the calcium accumulations in the osteocytes. And the cells stain positive for that. For the chondrogenic differentiation, is Alcian flow staining, which detects the polysaccharides inside the differentiated cells, and the cells stain positive for Alcian flow staining. For the adipogenic differentiation, we use oil red O staining, which detects the lipid fat accumulations inside the cells, and the cells stain positive for that too. So we have the stem cell markers in our isolates. We have one of the most important characteristics of stem cells, which are the ability to differentiate into different lineages. And the next step is to evaluate. So we are done with the isolation, passage, culturing, characterizations, and including the differentiation. So we are at this point here now So cells were divided into two different groups, one treated with hypoxic conditions and the second one with normoxic conditions. The cells will go for 24 hours, we will collect condition media and then we'll evaluate. So far we found that VEGF was the expression of VEGF was higher in the hypoxic conditions in comparison to the normal conditions, which is 21% of oxygen. So hopefully we will see similar results for the other cytokines and other growth factors. And hopefully when the grant is funded in future, we will go to the in vivo experiments and try to examine the effect of these cells and the hypoxic and normoxic conditions on the wound healing process overall. So this is a summary of what we have mentioned so far. And as the snow might participate in the regeneration process of snowmen, hopefully stem cells in future will help us to regenerate different organs and parts of human bodies. So thank you.
The next speaker is Dr. Sahar. I'm standing in front of you. My presentation this afternoon regarding the participation or impact of AI on or application of AI on clinical laboratories. Yes, here we are. The application of artificial intelligence in medical laboratories, this is what we are talking about today, and the impact of this great technology which developed later in order to serve our performance or to help in our performance in medical laboratory. So today, inshallah, we will go through the quick we will expose or go through the history of AI. Then we will talk about the role of AI in clinical laboratory and diagnosis. Again, the role of AI in research, how it's developed, and it's really support the researcher and has a highly impact in research and medical research specifically. And we will take a quick conclusion. So first of all, let's remind ourselves what's the artificial intelligence or AI. The AI is generally recognized as the ability to imitate human cognitive function using a machine. So this has happened through the ingenious association of computer science, algorithms, machines, machine learning, and data science. All these cooperate together to deliver the quick and good service to help in the field of medical laboratory. Also, AI can solve tasks within comparable performance to human or above their level. That's why this technology has a great impact on medicine in general and specifically in medical laboratory. Can I move on, please? Excuse me. Could you please put it on the view? view. Yes, yes. Full screen, exactly. So the IEA, it started from early decades in 1940s, between 1940s and 50s. The concept of the AI was started and inserted in the field of medicine. About the end of the 50s, the making of the correct diagnosis interpretation was the idea it might be possible to use this technology and process of all aspects of completely defined by machine in order of simplify and provide a quick service in the field of medical laboratory and medicine in general. Between 19 and 2000, many of these machines learning aided tasks have been largely accepted and incorporated into everyday practice of machine. This is what we widely can practice it today in the field of medicine and the field of medical laboratory, because the majority of techniques we used it as it's based on machine. So the using of AI was started in early years, which has a great impact. Recently, it's about 2020, just from a few months ago, the new fashion of AI was released to the use of public as a chat GPT, which is one of the applications. It has a great impact to improve and speed up the processing of the sample, processing of writing, the research, and so on. So why we this kind of technology or the AI as developed, or what's the aim behind it? Because it has a good advantage for continuous learning. We always using this technique to improve our performance, to speed up the work in the matter which is mimic to the human cognitive functions. So instead of wasting our time or using more and more effort to do the work, if we imitate this function, make it mimic to the human function, we can save our time and we can work on other more complicated tasks. Also, this AI has a great impact on increase efficiency. The availability of healthcare, specifically as a data, we have a huge data. We need to analyze these data frequently to have a good analysis and the result that might improve our weakness, improve our performance, and that will speed up again and again the service, which is very helpful for patients. With the speed or the fasting services are available in this field now, we need to advance technology that help us to process or to provide the service as ASAP. Also, this AI, it's improved or enhanced the accuracy whenever is the function is delivered exactly the same, and every time that will improve the accuracy. We in this stage or using this technology, that means we avoid the human being variations, and the AI use it in it will overcome this issue. So the impact of the AI on the medicine, it was classified in one of the reviews based on where we can use this technique. So a paper was published recently. They tried to collect all impact of AI or other or using artificial intelligence and its application in medicine and the clinical care generally as 3 phases, which the pre-operative, when we use the AI to improve the screening and diagnosis of the patients, and also to plan the treatment and follow up the patient as well. In the stage or in the phase of intraoperative, during the analysis of the sample, also the AI has a very helpful technique to tissue analyze, also interpretation, the result, and processing the sample. It will be, give us a very advantage to speed up the work and release the result for patient in very short time. Also, AI, it has helped us in the post-operative stage when the patient's already discharged from the hospital. We would like to follow up this patient in terms of taking the medicine, come back for his appointment. All these are the AI is helped greatly at this stage, and we can easily, we can find it, and we lived this experience recently because the advance or using the artificial and very good helpful way. So whenever we use the artificial intelligence in laboratory in screening and diagnosis, it was helpful, especially in the field of oncology. As a machine is developed in 2020, it shows, it's called fluorometry for analysis of blood sample to detect glycoblastoma with patient. It shows about 92% of accuracy. Again and again, using AI to diagnose the sample, especially with this kind of patients, they need the results to help them to start the treatment as soon as possible. So the benefits of this technology is to speed up the diagnosis of processing the sample, especially the histopathology sample, which, as you know, I guess most of you are expert in the field of laboratory, especially histopathology. Collecting the sample, cutting, processing, staining the sample, then looking and reading for the result. Interpretation takes about at least 3 days if we have a very expert teamwork. However, using the IA, that will really improve the processing of the sample and release the result in accurate and fast manner. AI-based radiomic program also is developed to predict the tumor marker expression and genetic mutations. Now, currently, in the field of genetics, there is published instrumentations that help to speed up the detection of genetic tumor marker whenever you process the sample on this instrument by quick screening for all tumor marker, positive and negative, and the microRNA or the DNA microarray. It's one of the example for this technology are efficiently used the AI to discover the mutations or genetic mutations in a tissue compared with the control sample. So all these, it's to provide accurate prediction and progress and recurrence of the disease. So whenever we look for these samples in a quick matter, that will improve the surface and release the result in appropriate time. As also the AI provide a statistically significant lower rate of the false positive, again because of reduce the variation between the processing of the sample due to the imitate the machinery which working in a very similar way between the samples that will reduce the variation. Also, IA support the complex decision-making for surgical selections. As you know, in the field, especially in diagnosis in of the cancer on oncology. The similarity, it is about maybe 60%. It's the similarity in the tissue. It is up to 60%. So sometimes the surgeon or the pathologist, he's under the making the final decision whether this disease, it is, for example, as a gastric due to one marker or another because of highly similarity to, using a model of AI that use definite control with imitate a model that will help the pathologist to have a decision and entirely have a final decision regarding diagnosis of this condition. So this is an example of the machine which is using the artificial intelligence in diagnosis of glioblastoma. They collect the sample of the patients, the glioblastoma, when they imitate the whole data collected from the patient by a standard way, then they save all data in a differential standard fluorometry. After that, in the second phase of validation this instrument, they collect the sample of different patients from has a glioma, and compared with the normal, when they analyze their sample, it gives a panel of different results. These the panel of different results or peak, which is the orange peaks here, represent a presence of cancer marker of glaucoma patients. However, compared with the blue peaks, which represent a normal patient. However, this patients who has still, there is positive markers here, but it's not relevant to the glaucoma, not comparable with the normal. It's indicate when they expose it to the atlas, which is arranged by AI machinery or machine learning automation. It suggests the presence of another type of cancer, but this group of samples, it's not normally match the normal pattern of the healthy people. Also, they applied, they comparing here in this, using AI in this instrument actually facilitate and speed up the classification of the samples to the 3 type based on what have saved previously from the traditional way for diagnosis of glaucoma. Also here we can see the advance in AI, or it has impact on diagnosis of antibiotic measure of antibiotic susceptibility using AI. The traditional way was we were looking for the culture for a few days, then read the result under the microscope to know, or by visual eye, to know either this sample is sensitive for this antibiotic or not. Currently, there is AI application. It's by mobile. You can download this and expose your plate for this application. It's give you very accurate result to read the sensitivity or susceptibility of samples for a specific antibiotic, and give the general complete report to release and directly used by the physician to really to plan the treatment for a patient. Also, the AI, it is AI, it is very helpful in intraoperative phase, as digitalization of the images in in order to diagnose the tumors. This is at a level of not only the medical laboratory, as a level of radiotherapy or radiology branch of the medicine, where they use a spectral signature, which consider as AI platform to delineate the tumor form of the normal tissue when we expose it for a spectral band of tissue. The model, it's widely used currently also. It is an example for intraoperative phase of AI, which is the Da Vinci robot, which widely used in surgical in surgery. It is called as a surgical report Da Vinci. This is the example for the Da Vinci report was used in worldwide to apply the operation for the patients. Here, the doctor, he can control moving the arm through the patients during the operation, and this is an overview diagram which illustrate how these robotics, which is totally managed by the AI, can help and speed up, especially for operation takes more than 6 hours, which is really difficult for a human being to focus for a long time. Here the AI, it is really very help for in this kind of operation with let's say limited number of medical staff to operate these cases for these patients. Also, at the level of post-operative phase, AI has a potential to speed up specimen analysis and to increase the accuracy of grading tumors, which is the major branch of medicine which gain the benefits of AI. It assists also to create the vaccine and modification by analyze the data which coming from patient samples, which stored, and it doesn't give us a direct indication whether this reason, what is the reason behind this virus or this epidemic. So the AI, it is one of the technology which help to quick and analyze the huge number of data to create a specific vaccine or to design a specific vaccine based on the criteria which saved and massive data. Help also to categorize the patient to aid the therapeutic and survival. In terms of post-operative phase, the AI sometimes, as you know, the conditions or the patients after diagnosed, each patient it has a specific conditions, different symptoms. So that just exposed the patient's data for AI technology that will help house this patient. What is the best treatment plan for this patient based on the whole data and the previous history. It is stored and machinery. Also, AI, it's able to predict the molecular and cellular markers in the tumor, maybe pave the way for highly tolerated therapy for brain. This is again, it support personal or personalized medicine. As we mentioned, each patient has a specific criteria or cause of the tumor, which is sometimes it is a challenge to describe the specific or the best choice of a treatment. The AI, it's helped to take this decision. Also, AI, it's continuous to benefit patient even after discharge via mobile phone application. As you know, as you see now, all of the hospitals, either governmental or private, they have their own applications. Whenever you leave the hospital, you can follow up your medical profile, your result of laboratory or radiology on the application. what is the treatment was prescribed for you. Either you can take a recurrent prescription or not based on the facility which is provided by mobile AI mobile applications. Also AI model to predict sensitivity of solid organ tumors to chemotherapy, which again and again it's help to support personalized medicine. This is generally summary of what artificial intelligence it's provide for medicine and public health. Actually, during the epidemics, many trillions of data was analyzed in a few hours and a few days because of the help or great impact of the artificial intelligence in terms of epidemics and also diagnosis using in a tumor and radiology. Also, it is has a great impact on the clinical trial performance, and what we will discuss it today as well, and retrieve of medical information for research and operation organization. This was take a great time to have a good answer, and sometimes it's not accurate. Today, in the clinic, the doctor he needs to chat with his patient and to diagnose his patient or understand what might be he has feel or what the patient suffer from. So whenever he has intelligent computer that track the chatting with the patients, whenever what he has or what he feel, what is the symptoms and signs of this patient, that will delivered as information, and complete report is written based on the chatting between the doctor and his patient within a few minutes, and give a suggestion. Whether is this accurate or not, we will talk about it later. So also the AI, it has a great impact on the clinical research on AI and machine learning in terms of create a synthetic control group by matching historical data to target trial enrollment criteria. This is actually, as a researcher, we face it frequently. Whenever we have an idea or research question, the first thing we struggle with is collecting the data. We're trying to find our target population to study. However, whenever we have all these data is imitated on machines simply by using a single word or few of keywords that will collect a population which is the target of for our research. Simplify and speed up the clinical trials through both more efficient recruitment and matching of study participants and more comprehensive analysis of data. This is technically, it is started to be used widely in our country. However, it is really used and applied as at a level of international research. Predict and understand the possible adverse events and patients subpopulations. Also, it can be this technique or this technology to help to classify the population as this is the best population to select or not. So this is an example. Whenever we have population with different background, with different ages, different genders, just using a few keywords that will classify the appropriate population, we can use it in clinical trials. Also, recently, as I mentioned, the fashionable application was released for public, which is called chatbot, widely used in research. The chatbot or ChatGPT was developed by OpenAI and released in November 2022. Since then, other chatbots has been released, and I believe most of you now using these applications to answer any random questions. So ChatGPT and other all AI application, especially GPT-4, which is improved to answer the medical question, because the expert who involved in this version of ChatGPT was expert of medical background, doctors, specialists, radiologists, surgeons. So whenever you ask for specific information in medical field, this application, it's 60% and above answer your question about to write. So the chatbot is a computer program that uses AI and natural language processing to understand the question and automate the responses to them, stimulate human conversion or conversation. On the surface, chatbot like ChatGPT are AA tool that can automatically generate a large quantity of text in a variety of style. Each chatbot has own strength and limitation. As I mentioned in previous slides, there is different application. By your using or practicing this application, you can determine which one is most appropriate for your field or not. ChatGPT, it's based on a neutral network that has been trained on 700 gigabytes of text in nearly 100 language. It used this large language model to generate predictive text in response to user prompt. Plagiarism. So whenever we ask help from the ChatGPT, we need to think about either it has a level of similarity, is it a kind of plagiarism or not, especially for the beginners researchers. They need to quick or speed up completing their task in research or in assignments. AI as creation tools have been trained entirely on data obtained from open resources on internet, such as open available model or medical text, research paper, health system website, and openly available health information, podcast and videos. Still, these source of information is not entirely approved or not entirely it has a copyright to have this information from these resources. So you need to be careful not use each single word delivered from these applications. This has a result in a formal statement from creators union, as well as unofficial boycotts from creator and public. So the ChatGPT as a good, helpful AI application, will provide you immediate answer for short question. It will sourcing technical definitions. It will identifying search keyword, generate prompt and formulate a question, structuring the research, but not argument, and also provide basic coding for your based on what you asked for. However, the chat GPT, it can't help you to original and distinctive expression. So whenever you release any content or text by chat GPT, it is easily we can detect this is not your own expression. We can consider it as a plagiarism. Also demonstrating and understanding and critical thinking, the chat GPT cannot help you with. Also structuring and refining an argument, it is very weak using these applications. Reflect on your practice and personal experience. It is again and again superficial. It doesn't give the exact information what you're looking for. Keeping to date research, all these information are collected from the open sources on the internet. Maybe it's not up to date, so don't depend on any of these information as a final or updated information to use in your research. Also, the accuracy or the accurate referencing and citation, you can't guarantee 100% this is the real reference of your answer of the question. So this is an example of how the ChatGPT cannot answer your question. For example, in this, when we ask a general question for ChatGPT to build or argue the statement, it gives it fails in a couple of the paragraphs. For example, in here, when we read what exactly is produced or the content from ChatGPT, we found this sentence is lack of argument. It doesn't fit with what we are looking for. So this is an example of the inability of ChatGPT or AI to answer your question or your research question as what you expect. Also, in another paragraph, when we look for within this paragraph, we found there is a referencing issue that doesn't indicate, although it is giving the citation mark here, but it doesn't refer what is the source of this statement. Again and again, the weakness of this chat, it is when you look for the internally into the text, it doesn't reflect the depth, what you at a level of a professional writing the content, like in the fourth paragraph, which shows there is a lack of the depth because it is just written content without answering the major question of argument. So in conclusion, the AI as a system, it's a series of increasingly powerful tool and generally intelligent machines. These machines are tools and not as any tools, as a mobile, as a computer. They can be used for good, but it have the potential to cause harm. We cannot definitely rely on these applications to build our reliable research or medical decision to diagnose patients. If we used carefully with an appropriate degree of caution, these evolving tools have the potential to help healthcare providers give the best care for the patient. That's all for my speech today. Thank you for your attention. It's a bit longer speech, but hopefully it is useful and valuable information. Any questions? Okay, the next speaker who's yes. Our speaker now is Dr. Mu'in Hasib. He will talk about the starting of a post program, what you need to know.
Assalamu alaikum. Good afternoon. Today, inshallah, I'll talk to you about a point-of-care program, what you need to know. The learning outcome for this presentation will be what is point-of-care, to point-of-care or not to point-of-care, what is the CAB accreditation requirement for it, what do you need in order to establish a point-of-care program? What would the inspector, the CAB inspector, look for when he inspects you? Okay. And how to achieve quality in point of care and summary. What is point of care? Point of care is testing at the point where the patient care is given, where is given or located. Okay. These tests are generally performed by staff not formally trained in a clinical laboratory, such as nurses, respiratory therapists, care techs. So point of care has been available in more than 35 years. Example of that would be where is given, the point of care is given. It's at the bedside, doctor offices, surgery, emergency room, and in the field, like in the ambulance. What is point of care? Example of, we still in what is point of care. Example of tests that can be done as point of care is blood gases, lipid, cardiac markers, hemoglobin A1C, pregnancy, blood gases, and many more. Now the big question is, to point of care or not to point of care? Point of care often starts in a hospital setting without knowing if the testing is appropriate for that setting or not. Many times there is a limit understanding of requirement for accreditation, training, documentation, and procedure. There might be several types of instrumentation performing the same testing in various areas of the facility, which is not good. Now, there may be also no evaluation or comparison of the values obtained from these different methodology, and they may not correlate well with each other. Cost saving that may be available through the quantity purchase may be lost. It is important that a point of care program at any of the above site is carefully planned and evaluated. What are the advantages of having a point of care program? Speed, definitely. Point of care can take, in some studies, 8 minutes versus about an hour in the lab. Therapeutic drugs turnaround time, 8 minutes versus an hour and 25 minutes. Now, another advantage of point-of-care testing is dummy-proof. What does that mean? It's just push button. You don't need to be smart in order to operate a point-of-care machine. Might not need permanent dedicated space that lab required. In the lab, we have big machine. Point of care usually are small. You can just move them around. Also, the entire process from collection, analysis, repeat analysis if needed, immediate result review, and patient education are at or near the bedside. Likelihood of wrong result is also small. Point of care testing will reduce the hospital length of stay, and you will have fewer unnecessary admission. And lastly, you have a very small blood sample with point of care compared to the lab. Next, we're going to talk about the disadvantages of having a point of care test. It could be inaccurate or less accurate than the lab result. Second, could be costly. It's not totally under the control of the lab because it's not done by laboratory personnel. Hard to keep track of inventory and supplies. Hard to monitor and track of QC and maintenance. Testing is performed by non-laboratory people, end users. Operation of end users might be an issue. Okay. End user might take shortcuts when doing the procedure. They're not following the SOP as written. Hard to keep track of the end users or the staff. And the last thing is hard to keep track and perform the end user training and competency, which is a very, very big thing in point of care. Next, we're going to talk about some of the most required things by CAB, College of American Pathology's accreditation requirement for point of care program. Okay, point of care in CAB, they have their own checklist. They have a checklist called point of care testing. Okay. And POCT stands for point of care, and this is the standard 06800 authorized point of care personnel. As a lab, we need to keep track of those who perform the point of care testing. You need a roster of everybody who is performing a point of care testing. Like I said, it's very, very hard to keep track of, especially in places where the turnover is very, very high. People lose every month. You have people coming, people going. So the second requirement is the initial training. You have to have a training for those who are using the point of care devices. A certificate is okay, but I recommend a checklist. Okay, checklist, detailed checklist like cookbook instructions that have each step of how to perform a test on a point of care device. Okay. Next requirement is the quality control must be performed according to the manufacturer instructions. This is for wave test. And for those who are performing wave tests, always remember this. We follow manufacturer instructions when we are dealing with point of care testing for wave tests. Okay. However, in this checklist, it says daily quality control must be run as follows. Quantitative test, you need 2 sets of control, okay, at different concentration daily, except for coagulation, which is needed once every shift, once every 8 hours. So the expiration of the QC, some people think that the expiration of the QC is just expiration of material. Actually, there is some expiration we call expiration of time. The QC material could be still good, but 8 hours is 8 hours. That means your QC expired, you need to run the QC again. Time expiration. Also for blood gases, as will I tell you in a minute about it, that you need to run one level of QC of blood gases if your machine is performing calibration every 30 minutes. If your machine is not performing calibration every 30 minutes or not programmed to perform automatic calibration every 30 minutes, imagine you need to run one level of QC with each patient. See the requirement? So you have to be careful with that. Blood gas machine, coagulation machines are now capable of being programmed to do the QC every 8 hours, or one level of every 8 hours, or 3 levels for coagulation, or 2 levels every 8 hours. When I check the QC, especially for coagulation, I check that the QC is done every 8 hours. Because they could have done, like say, you could program it to do it 3, 7, 11. 7 a.m., 3 p.m., and 11 p.m. If there is no QC between 3 and 5, my question would be to them, did you do any patient between 3 and 5? If they did, that means they ran the reported patient when the QC was out of time, expired. Okay? And for a qualitative test, you need a negative and a positive control at least daily. You need, in order to comply, you need a written procedure and you need records to prove that. Okay? Oops. For non-waived, for a quantitative and qualitative test, controls are run at least daily. Okay, or more frequently if specified in the manufacturer recommendation or the laboratory procedure or the accreditation requirement, or when changes occur that may impact the patient. I already talked about the quality control establishment or verification in my previous talk. Okay, when you get a new QC lot, you're supposed to verify it. Okay, if it's an assayed control means comes with ranges. Okay, if it comes with ranges, all you need to know to do is just run it once and check your result that comes out of from the machine. If they are within the ranges that came with the lot, you are considered verified. If your verification failed or you have unassayed QC material which comes with no ranges, then you need to establish your QC ranges the old-fashioned way, run 10, 15 times, do the mean, then calculate the mean and the SDs. Whenever your QC is out, you have to have a corrective action. Like I said in my previous talk, you need to repeat till you are within the 2 SD, or okay, and then you need to fill a corrective action form. What else? QC handling, we already talked about that also in my previous talk. Those who are running patient tests, they're supposed to be doing QC also. QC of confirmation, we said there are 2 kinds of confirmation, 2 kinds of check-in for the QC. One is done by the technologist or the person who is running the QC. Before they report patient result, they're supposed to make sure it is within the acceptable limits. Okay? And the second check is monthly by the medical director or designee. They're supposed to be checking the reviewing the QC and signing and dating on a monthly basis. We already talked about the blood gases, so I'm not gonna repeat it. You need one level of QC every 8 hours if your machine calibrates every 30 minutes automatically. Okay, if you don't do that, then you need to run 1 level of QC with each patient, which is very hard to do. Okay. Now, verification of test performance specification for American FDA approved test, or C for non-US labs like us, CE, which is a European approved test also included for non-US labs. You need to do accuracy, precision, and reportable range, which is, by the way, AMR or analytical measurement range, reportable range, linearity, calibration verification, they all mean the same thing if the material used cover the range of the AMR. Okay? And the reportable range for the AMR is the only thing after you finish your verification you need to do every 6 months for quantitative testing. Qualitative testing is NA for it. Okay? So you need to do accuracy, precision, quantitative testing, you need to do the reportable range, and you need to verify the reference interval. Fortunately, for blood gases, you don't need to verify. Why? Because the ranges are international. When the ranges are international, then you don't need to verify the ranges. So you are exempt from this. And anybody who wants to study to prove that, I have it, I can send it to them. Then the method validation verification approval needs to be approved by the medical director or designee. A designee for approving validation verification, ordering PT, proficiency testing, reviewing of proficiency testing, has to be done by the medical director or a designee. A designee is who's considered a designee for these things is PhD, MD specialized in that section. So for QC maintenance, I told you a technologist can do it. But for the other stuff, it has to be MD, PhD specialized in that section in order to be a designee for the medical laboratory medical director, and it has to be in writing. Okay? What else we need? What do you need in order to establish a point of care program? I really, first of all, you need authority. I mean, authority from the CEO, authority from the director. They need to tell you, we need you to establish a point of care program. If you don't have authority, you will not be able to do it. Okay? Then you need a full-time point of care coordinator if you have a large program. If you don't have a large program, a part-time will do. Okay? Then need a point of care committee. I highly recommend this, especially in the beginning of establishing a point of care. Why? Because you will get everybody involved in point of care from all sides, from all places, to come into one place and talk and agree on things. Because if you're going to do it by email and by memos and stuff like that, is not going to work. It's going to be very, very hard. Also, when you have the people in front of you, face to face, eye to eye, they commit. They commit, and when they come back to another meeting, they need to deliver. You said, I'm going to do this, I'm going to do that, I'm going to do this. Then when they come back, you say, yes, I did this, I did that. So that's another reason for that. So you need to include a pathologist as chairman, usually the medical director. You need a physician, nursing manager, educational coordinator, laboratory manager, quality assurance manager. Any place where you're going to be put point of care, you should have a representative on the committee. And purchasing and IT representative should be used as a consultant or as a help. When you need help from IT or purchasing, they should come to the meeting, but they don't need to be there all the time. What else you need? Okay, committee, you need a policy, and the committee need to define who's going to be doing what. The task, okay, like for example, the point of care coordinator, keep database of testing personnel, coordinate training for new personnel and competency, monitor QC and PT program. Nursing manager, enforce policies, scheduling new employee training, schedule annual competency of staff, and the most important, nurse educator, who's going to be doing the training, who's going to be doing the competency on these point of care users. You, as a point of care coordinator, if you are one, you really have to have a good relationship with the nursing coordinator and the nursing manager, because they can make your life easy and can make your life difficult. you need to do initial evaluation, okay, for wave tests. And try, when you get an instrument or a machine for point of care, try to have it as a wave. Why wave? Because it's less work for you when it comes to validation verification. For wave test, all you need to do is just compare it with the main lab. But if you get an unwave test or machine, then you need to do the whole things I mentioned: accuracy, precision, AMR, reference range, and sensitivity, specificity checking. You need to do all these things, okay? So initial evaluation item could be include cost of hiring, okay, and training, labor associated with the process and analysis specimen, labor associated with maintaining the equipment, annual reagent control maintenance and depreciation cost, cost of accreditation according to volume and test complexity, cost of BT program for testing performed. Implementation could over a year. So if you're thinking you are preparing for accreditation and you want to start a point of care program, I say wait till you finish with the accreditation, then you will have 2 more years to implement the point of care program, okay? So implementation of point of care program should include following manufacturer instructions if given. You need to follow your laboratory method validation verification SOP. Staff existing and new, they need initial training, annual recertification and competency. Okay? Result reporting protocol, quality assurance program. You need QC, maintenance, BT, documentation, and evaluation. Like I told you, initial evaluation, implementation, point of care testing program could take over a year. Then you need to do periodic monitoring and evaluation. Why? In order to assure that the program is meeting the need of its customer. This can be done by using quality indicators, customer surveys, feedback, review of QC, maintenance, and PT results. Also, you need to keep your record. This is very, very important, and many people do not know this. PERCAB, College of American Pathologists. If you do not keep your records centrally in the lab, means you collecting the QC on a monthly basis, you collecting the maintenance on a monthly basis, okay, and keep it in the lab, either in the point of care coordinator office or in the medical director office, then CAB will inspect each point of care site with separate checklist. So if you have 20 of them, then they will do 20 inspection for 20 sites. But if you keep your records centrally in the lab, then they will do selective sites and do the inspection for them, as I will tell you in a few minutes. Okay? What would the inspector look for and inspect? Now, when the inspector come, okay, he will visit a representative of the point of care sites. Usually, they will look at the high and low volume, different type of testing personnel, nursing, ABG personnel, surgery, and that represent of all tests performed and instruments used. So they could go to ER because usually they're doing the most, or surgery, or they want to see some respiratory techs and stuff like that, or ICU, or OB. So what they will be doing for the staff? They will be interviewing the staff, okay? So you need to train these staffs on how to answer out, okay? First, they need to have, they will ask him about proper patient identification. 2 identifiers. What's your name, medical record number? They need to identify the patient by 2 identifiers. How they collect the sample and how they label it, okay? At least 2 identifiers also. And then test the procedure performance. They want to make sure that those who perform point-of-care testing, they are following the procedure. If they don't follow the procedure, then they will be cited saying, practice does not match procedure. Okay? They will observe doing QC, and they will check the QC and the maintenance and patient result reporting and safety practices. Now, how to achieve quality in care testing? Like I said, you need a committee, which is highly recommended. You need a point-of-care coordinator, which is recommended for large places or institutes. You need to do method evaluation and verification. You need to have training and competency. You need to have QC, maintenance, PT. You need to control point-of-care devices, inventory, and supplies. You should have all these things centralized. No machine, no instrument, no kit should be put on the floor unless approved by the point-of-care committee. Anybody can bring just a kit and just put it on the floor. It has to be approved by the point-of-care committee. That's how you control supplies. Consult before you buy. Okay, the salespeople, they always want to sell. Okay, so you need to consult with whom are using that machine or using that kit. Call them, ask for a list of users, call them, say, and call some of them. Believe me, they will tell you if they're happy with it or not. Also, you can use these websites to find out about a machine or a kit, if it's waved, non-waved, if there is any problem with it, okay? To summarize, if you don't have a program, and like I said, then you're thinking of one and you want to go through the accreditation, wait till you receive your accreditation, then start the point-of-care program, because you'll have 2 or 3 more years in order to implement. Look at the advantages and disadvantages of anything that you do when it comes to point-of-care. If you have a program, you need a point-of-care coordinator, whether a full-time or part-time. You need a committee. Okay, you need to control purchasing of equipment and instruments, and check out the repetition of the vendor. What else? Make sure your equipment and instruments are waived if there is a choice. Dummy-proof, user-friendly. They lock themselves if the QC is not done. When they lock themselves, that means nobody can use the machine unless you do the QC, okay, or you repeat the QC. This will save you time when you are checking the QC on a monthly basis. Be aware of connectivity and computer system. This is very important. If you're buying, make sure connectivity with the LIS is included, because they might sell you the machines, and when you want to connect, they will tell you, well, that was not part of the agreement and we need you to pay extra for that. So make sure connectivity and computer is, what's that? Can you close that page? Ask vendor to help you with the training also. Train the trainer. They can train your people, okay? And then your trainer can train the others. Initially, training should be detailed, like I said, preferred, but a certificate is okay. And on an annual basis, they need competency. Initial evaluation, verification, and approval, make sure it is done and approved by the medical director or designee. You need to have QC, maintenance, and PT, and SOPs or policy procedure need to be what we call dual approval, lab and nursing, unless there is a committee and the chairman can sign for these IPPs, because he or she a representative of every of everybody. That's it. Thank you very much.
The next speaker, the last and next speaker for our last session of the in the conference is Dr. Hussam Ganesh. Dr. Hussam, he will present today the extrema page improve erythroid differentiation in a human IPCS model of diamond plaque fan anemia. تفضل دكتور حسام.
Assalamu alaikum. Thank you first for the great introductions. Actually, we are just getting back to the stem cell again after the doctor already mentioned on very great information about mesenchymal stem cell. But here we are going to talk about one of the most type that's being used a lot since 2006. After Yamanaka, invented this kind of thing for RBC, which is induced pluripotent stem cell working as embryonic stem cell. So I just want to here show you how we were able experimentally in the lab back in the United States in collaboration between University of Halle and the National Institute of Health in the United States to improve the erythroid maturation in the one of the common anemia called diamond black fan anemia. So here is my disclosures for the presentation today. So diamond black fan anemia is a disease named after Louis Diamond and Kenneth Blackfan, and one of the most autosomal dominant bone marrow failure syndrome that's primarily characterized by defective erythropoiesis. In most patients, the pathogenic mutations have been identified in genes encoding ribosomal proteins. In 25 of those patients, these kind of mutations have been identified in ribosomal protein small 19 or RBS19. So this RBS19, along with other ribosomal protein and ribosomal RNA, can form the 40S small ribosomal subunit. And the 40S in our body in the eukaryotic, along with the 60S large ribosomal subunit, can form the total eukaryotic 80S ribosome. But in case of haploinsufficiency or ribosomal protein small 19 haploinsufficiency, we are going to see a reduction in the 40S, resulting in a reduction in the ratio between the 40S and 60S. And finally, we get a reduction in eukaryotic 80S. So let's ask a question here. How does this ribosomal protein haploinsufficiency cause a defective erythropoiesis in DBA patient? But before going to answer this kind of question, let's just understand the normal erythropoiesis in our body. Actually, as we have the erythrocyte here, the mature erythrocyte that contain a hemoglobin molecules, which is a protein, an oxygen-binding protein that has a four globin chains. In adults will be 2 alpha, 2 beta. And also there is an iron bound to the heme group in this hemoglobin. These erythrocytes are successfully developed from all progenitors, BFU, CFUE, proerythroblast, and more mature basophilic, polychromatic, and orthochromatic erythroblast in our body. These early progenitor cells upregulate a transferrin receptor, which is a CD71 that's allowed the uptakes of iron in our body. And after that, the heme begins or is upregulated to synthesize at the early stage of the proerythroblast. And once we have the heme that being synthesized, we are going to get the globin to be produced. And this limited delay between the heme and globin is very important, as if we are going to have more free heme inside the cells, that is going to cause what's called a profound cell toxicity and cell death. So in normal individuals, the hemoglobin is balanced. So the hemoglobin ratio is balanced, resulting normal erythropoiesis. However, in the DBA patient, we are going to get the cell arrested at the proerythroblast here. And due to the problem of the ribosomopathies in those patients, we are going to get, a delay in the globin. So the globin will be delayed, whereas at the same time, the heme proceeds normally. So the balance here, it's a little bit weird, as there is going to be a prolonged time or a prolonged period of time when we have heme exceeds globin, causing cell death. So the balance that we are going to get more heme compared to the globin inside the cell. So there is no balance between the heme and globin, resulting in abnormal erythropoiesis. So we hypothesize in this kind of project how we can delay the heme productions by using kind of the iron chelations. And nowadays there's many iron chelators that can be used, but in our case we are going to use a small drug called Altrombobag. So then after that we can limit the delay between the hemoglobin synthesis in this patient and reestablish the globin and heme ratio, resulting in the normal erythropoiesis. So given the critical role of iron in heme productions, so we just say that the delaying heme productions that might help, and we can create the iron which is responsible to do or produce the heme by using Altrombobag. So to test Altrombobag, or to test whether the Altrombobag can improve erythropoiesis in the DBA or not, we actually first create a model of the disease IBCs by de-differentiating the somatic cells using the 4 common transcription factors, and just transduce the somatic cells with the Yamanaka transcription factors, CMYC, CLIF4, OCT4, and SOC2. And after that, we get the disease IBC. But we transduce those cells using an unintegrating virus called Sendai virus. Then we just, get a control model by just using a CRISPR-Cas and create an isogenic IBC line, which is going to be a control embryonal to the disease IBCs. And after that, we get both models or both IBC cells, and we just induce them into the mesoderm differentiation to get the blood cells at the end. And we trade those cells during differentiation with Altrombobag. So simply, we use 3 different strategies. First, we generate and characterize DBA IBC lines. After that, we generate and characterize isogenic IBC lines. And then we just induce those cells into erythropoietic differentiation for 21 days in the presence or absence of Altrombobag. So the first thing that we get here, we measure the proficiency, or I would say the efficiency of reprogramming using alkaline phosphatase here technique. We just achieve a high reprogramming efficiency of our cells is around like 0.5% efficiency, which is almost 2 log more compared to what that has been published in the recent paper that they get around 0.00445%. That's around like 2 log more but because we use a syndivirus in our technique and they use a lentiviral vector. And through the sequencing, the single sequencing, we confirmed that's the point mutation in the RBS19 gene in those patients. After that, to confirm the pluripotencies of the DBA IBCs, we run the flow cytometry and we measure the pluripotency marker TRA160 and NANOG, and we just found those cells were more than 96%. I would say 90% in the NANOG and 96% in the TRA160. And through the teratoma assay, after we get some mice injected, and within 12 weeks, we harvested the teratoma formation, and we run the immunohistochemistry to identify the 3 different germs layers in these mice, and we get ectoderm representing bineural tube, mesoderm representing by the gut cartilage, endoderm representing by the gut-like epithelium. Then, as I just mentioned in the beginning of the presentation, that the DBA is a ribosomopathy disease. So we just check the bolosome profiling of the DBA IBCs. Simply, we seeded the IBC cells for some days, then incubate them with a cyclohexamide, and after that, we just get the cell lysate and introduce this through the syringe into the sucrose gradient that's from 10 to 50%. And we separate using ultracentrifuge, and the concentration of each band was measured using the Biocom gradient fractionator. So if you look on this graph on the left, it's very obvious that we get a high, expression of the ADS or the concentration of ADS in the wild type is very high compared to the DBA IBC line that we made it. And here is showing the significant reduction in the DBA patient compared to normal in terms of the 40S/60S ratio. So after that, just we created the model, the control model that's representing the phenotype of the DBA, but this is isogenic IBCs. Simply, we get those DBA IBC cell transfected with a component, with a CRISPR component, including the mRNA expressing Cas9 GFP, guide RNA targeting the site of interest, and also the SSODN, which was a donor template in our project. And after 2 days, we sorted for the GFP positive IBCs, and then we rebladed those sorted GFP positive IBC into a 96-well plate as a single cell, and within 12 to 14 days, we just run the restriction enzyme, and we confirm this through the sequence to just get what's called the isogenic corrected IBC cells. So the sorted cells in our case were around like 64.1%, which is quite high. And after we just collect those cells and extracted the DNA and using the restriction enzyme called ASC1 digestion, we get around 19 out of 60 clones that represented 32% of the correction efficiency. Then we just try to confirm the sequence again for the isogenic line, and as it can be seen here, we get this single mutated cell that's already being corrected. So also by Western blot, as you can see here, in the ribosome, the RBS19 haploinsufficiency can be shown here as a faint band in the DBA patient compared to the isogenic IBC cell, which represents very bold band. That's mean a high expression of the protein in the isogenic IBC compared to the DBA. Also, we just confirmed the pluripotency again for the isogenic line, and we get a high expression of the pluripotency marker TRA-160, and nanog. And also we confirmed the presence of 3 different germs layer: ectoderm, mesoderm, and endoderm. And we run the karyotyping, and we get a normal karyotyping in terms of genetic integrity for the isogenic IBC line that we created. Then we just run the polysome profiling assay again to compare the isogenic and the DBA patient, and as you can see here, there is a reproductions of the RBS19, so that means there is an increase in the 40S, which lead to have an increase in the monosome ADS large, or a total eukaryotic ribosome, and here a significant increase in the isogenic line for 40S, 60S ratio compared to the DBA patient. So here is the most important point of our project. After we created both lines, the DBA IBCs and the isogenic IBCs, we just differentiate those cells into the blood cells for 21 days in the presence or absence of a thrombobag, which is an intracellular iron chelator, along with 2 different controls here. DFX, which is a diffracyrus, is intracellular, the same as a thrombobag, and diffraxamine, which is extracellular iron chelator. And we just collected the cell at day 19 and 21. So by the colony forming unit, as you can see here, we get productions of erythroid colony in the isogenic, but not in the DBA IBCs. But with the addition of EBAG, we get those cells coming back again, and we get erythroid colony, and we got almost the similar result for the DFX. Both are iron chelator, but they are working intracellularly. But however, we get almost nothing here with the DFO, which is extracellular iron chelator. Here is a summary graph. As you can see, there is a reproductions of erythroids colonies in the isogenic IBC, and was a significant increase compared to the DBA. Our thrombobag almost get the same result for the cell that's being treated with thrombobag, and also similar result to the cell treated with a DFX, but you know, the DFO show almost the same result at the DBA IBS line, which is make that's very simple logic, indicating that a thrombobag mediating iron chelation can work as an iron chelator, and the mechanism that will be intracellular, not extracellular. So then by a flow cytometry, we try to evaluate the stages of erythroid maturations. And we just, distinguish these stages into 3 different populations. Population 1, which are the cells that express CD51, APO receptor, and CD45. And also population 2, that the cells are expressing CD71 but has a low expression of APO receptor and CD45. Population 3 include the cells that are expressing only CD71 but not APO receptor and 45. Then what we get here, I just need you guys to look at the B3, because this is our interest of our population of interest. As you can see here, there is an increase in the B3 in the isogenic, but almost nothing in the DBA, which is make that symbol to us that the DBA cells or erythroid cell can be, arrested at the early stage. After those cells treated with a thrombobag and DFX, we saw this B3 population, getting back, not to the normal, but I would say it's like it's a partially improvement in erythroid population, the more mature cells, but nothing with the DFO cells. Here is a summary graph of the DBA cell treated with a thrombobag or DFX or DFO or alone, and the isogenic line by distinguish 3 different populations. Again, as you can see here in the B3, there is a significant increase in all populations. I would say in B2 and B3, but not in P1, that's showing an increase in the erythroid, more maturation cells in the isogenic IBC line compared to the DBA. In the presence of the EBAG, also showing the same result, but less significant. And the similar results have been documented in the DBA treated with the DFX, but not with DFO. So here is just a take-home message for you guys to know what has been done in this kind of project. We achieve a high reprogramming efficiency of somatic cells after we get the mononuclear cells into IBCs for disease modeling, and also the isogenic IBC ensure that the DBA phenotype observed in the IBC drift cell is driven by disease-specific mutations. The most important thing here that's the directed differentiation into the erythroid differentiation of the DBA IBC recapitulate the early erythroid maturation defect as being arrested in the pro-erythroblast cells. And I would just, say that this is the important point of our project, showing that a partial rescue of erythroid or erythroid maturations when we're using either one, the EBAG or DFX, and they are both working as an intracellular iron chelator. And our data just support molecular mechanism based on iron chelation. Before going to thank you slide, I just want to acknowledge all the names written here, the people from the NIH, different branches, National Heart, Lung, and Blood Institutes, the La Rochelle Lab, where we work a lot on this kind of project, of this project, the IBS core, the University of Halle, which funded this kind of project, and the College of Applied Medical Sciences, and also special thanks to the hematology flow core, that's the KFAN, who help us with flow cytometry a lot. Thank you so much, and I'm happy to have any questions.
وفي الختام نشكر الحضور الكرام على حضورهم، ومن لا يشكر الناس لا يشكر الله. حان تكريم المحاضرين الدكتورة سحر والدكتور عبد العزيز. تفضلوا على الستيج يا دكتور. أولا نكرم أخونا الدكتور سامي المالكي في قسم المختبرات الطبية بكلية العلوم التطبيقية بجامعة المجمع على ما قدمه من إثراء حول البحث، فليتفضل مشكورا. كما نشكر أخو استشاري الدكتور حسن علي قنش على ما قدمه من إثراءات حول البحث. حسام دكتور الاستشاري حسام علي قنش. الختام عند الدكتور عبد العزيز.
يعطيكم العافية شكرا على حضوركم. This conference is actually a hybrid conference. We have a bit more than 100 online on one on the Teams, Microsoft Teams. On the YouTube, we have also maybe several hundreds, I'm not sure. So thank you very much for coming. Thank you for giving us your talks. I hope whoever attending behind the screens has benefited from these lectures. Thank you very much for coming. Inshallah, next year maybe, or the following one.